She would have been in the nursing home, would have had somebody having to give her medications. We don't know if she could swallow, she could not speak. So her deficits have decreased significantly, and her quality of life is much better from the treatment. It's my favorite case ever, right? This was our actual first thrombectomy that we did at St. Joe Hospital since I was in a role. And we had a 47-year-old guy. He came up from Potomac, Kentucky. I don't know where. There was a whole truckload of them. They came up to put a roof on a building. They're roofing this building. They come down for lunch. He eats his bologna sandwich, and then he goes to smoke a cigarette. He's like, "Linda, can you light my cigarette for me?" You can't do an arm move. So Linda lights a cigarette, and he smokes some of it or all of it. I don't know how that happened, but he progressed significantly from the time he couldn't move his right arm until the time he got into our hospital. Nobody really knew anything about him, so we don't know his allergies, we don't know his history, but he had that sudden right-sided weakness and aphasia. He had a blood pressure of 139/80, so he was in the treatment range. He had a pulse of 81 that was regular, sats were 95%. His temp was 98.3, and he was 90 kilograms, so he would get a full maximum dose of TPA. He came in with his last known normal of 120, and that was with his guys that were with him that lit a cigarette when he couldn't move anymore. They put, there was no pre-arrival notification because he was rolled out by his buddies at the door. Came through the door at 13:43, his glucose was normal. He went to CT scan a few minutes later. There's a bit of a delay here in the CT scan, and this is another piece that's hard to stomach when you're the one pushing the stretcher. So if you come into the hospital and they stop you to register the patient, it feels like it's done. Like, why am I standing here with a patient getting them registered? I don't care what their birthday is. I don't care what their social security number is. Put them on the CT scanner and let's treat the patient. So there can be a delay in the registration, but the reason for that delay in registration is it decreases the delay downstream. So if you take a couple of minutes to get the patient registered here and then go to CT scan, you don't have to connect the images to the chart to get them to the radiologist later. So if you wait a couple of minutes here, you can save 15 to 20 minutes here to try to get the image to the radiologist. So it feels bad when you roll in and you're standing there thinking we're not doing anything, but it truly decreases the amount of time until the patient can be treated because it gets the images to the radiologist in a different manner. Puts it up at the top of their list like super chat. So you want to wait, even though it feels bad. Does that make sense? So by the time he got to us, he was an NIH stroke scale of 19, which is a significant stroke. He was completely paralyzed on his right side, had a gaze deviation. I mean, he was sick. He got his TPA bolus at 14:27, so he had a 44-minute morning time. We took him for a perfusion scan, and this is actually his imaging. We could salvage half of his brain. So this right here is the skull, and this is all brain that's not getting perfused. Half of his brain is not getting any oxygenated blood. So we pulled this blood clot out with this device, which you probably can't see, and then we reperfused this half of his brain. So it's the same picture here, but all of this is reperfused over here by pulling that clot. On the CT, or on the cath lab table, he raised his arm underneath the sheet. It was that significant, right then and there. He went from an NIH stroke scale of 19 to a 1. I joke that I don't think he had any slurred speech. I think that was just his accent from where he was from. I think that was just his drawl. I don't think that was his slurred speech. But he walked out of the hospital 3 days later. He refused a wheelchair and walked out. So you've got a 47-year-old healthy man who's roofing, so he's physically healthy, who has a stroke. If this stroke had not been treated, he would have been in a nursing home for 20 years. He would have been in and out with UTIs. He would have been in and out with aspiration pneumonia. He'd have had a feeding tube if he had lived, because his stroke was significant enough where he could have swelled and needed the hemicraniectomy and herniated. Who knows what could have happened to this guy? But his impact was significant. But 3 days later, he went home. He walked out and went home because of the treatment options. So we've talked about a patient that had TPA. We've talked about a patient that had TPA and thrombectomy. which is the ideal case. He is the ideal case to have both treatments. The interventional doctors like the patients to have TPA first because it makes the clot slippery, it comes out easier. So you want to, if the patients are eligible, you want both treatment options. The next stroke we're going to talk about is what's called a wake-up stroke. Has anybody heard of a wake-up stroke? This is the patient that goes to bed the night before. Nobody sees them. The next morning, they're not normal. Nobody knows when their last known normal. So they wake up as a stroke. They likely woke up and stroked, but we're not able to determine that for sure. So they're outside of the TPA window because we don't know when their last known normal is. This was a 64-year-old lady, history of hypertension, microbiome repair, COPD, allergies, latex, sulfa, blah, blah, blah. Right side of weakness and numbness, vitals were 148 over 86, pulse was regular, stats were 94, so we could have put her on 2 liters of oxygen at 94%. Temp was good, and she was 75 kilograms. She could get a 0.9 milligram per kilogram dose of TPA if she were eligible. She's not eligible because we don't know her last known normal. So at 9:30 Monday night, her family left her, and the next day they went to check on her at like 2 or 3 because nobody had talked to her, nobody could get a hold of her. So the next day they saw her at 2 or 3 in the afternoon. They did not call EMS, they brought her in to the hospital. She got to us at 15:57. Her glucose was 92, which is normal. She went to CT scan. And if you'll notice, most of the patients that didn't have an EMS pre-arrival had a little bit longer time to get to CT scan. So she went to CT scan, had an NIH stroke scale of 8, which is a moderate stroke in our scoring. She did not get TPA, and she was considered a wake-up stroke. This is her images. So this is her skull here. This half of her brain is not getting perfused. We pulled out these clots with this device and reperfused everything from here up. She was in a NIH stroke scale of 8 when she got to our hospital, and she left with no deficits. She went back to her home with no deficits. So this patient is way outside of the window, and this is likely a patient that you would have been bringing to St. Joe London. But this is the exact patient that you need to go ahead and get to Lexington to have the perfusion scheme to be assessed for thrombectomy instead of bringing them here and let them sit. You know they're not going to be getting TPA because they don't have a last known normal, and that patient can go on to Lexington for perfusion scan. So the things we want you to know is know where to go to the hospital, know which hospitals will give TPA in your area. I'm not able to tell you which hospital to go to or not go to, but you need to know your area as who will give TPA and who will not. All ERs have TPA, and all ERs can give
I'm just confused because when that physician came from Central Baptist,
Uh-huh.
he said to fly all strokes to Lexington, all strokes.
Yeah,
Like,
Dr. Gagnon.
he said that you could remove a clot up to like 18, 20 hours after the event.
Yeah.
You can.
So he basically said if you had a stroke patient, you put them on a helicopter and you get a Lexington. So I'm kind of confused on,
So if you have a patient that calls you,
because you're saying,
if you have a patient, if your mother has a stroke and she calls EMS at 3.5 hours from the last time she was normal, and you have 1 hour to get TPA in her, and you know that it takes the hospital 1 hour to give TPA, whatever hospital you're at, do you want to be the one that makes the call of, I'm gonna knock her outside of the TPA window, which means not make her eligible for a treatment?
I mean, I see what you're
Supply.
saying, but I've worked alongside St. Joe London alongside them for 6 years, and I'm not impressed. And I'm not trying to be disrespectful at all, but I wouldn't want anybody in my family going to St. Joe London for any reason that was a true emergency. And I'm not trying to be disrespectful at all, but I mean, that's what we've seen here. So I want my family in Lexington. I'm just
You
being
realize
honest.
she's with St.
I
Joe.
do, but I'm being honest. I
No, we want to hear the feedback, you can't fix it
I'm
if you
being
don't know.
honest. I'm not
She's
being.
You can't fix it if you don't know.
No.
What I can tell you is that there is a focus on stroke care at all St. Joe Kentucky One facilities. I can tell you that there is an algorithm that is in front of the physician desk right now, which leads them to give TPA to patients. They have all had education and they are all treating stroke different than they used to. So what I would like to ask